these slides summarize the possible advantages of early spontaneous breathing in patients with ARDS. It may preserve the respiratory muscle function, preventing respiratory muscle weakness. It may improve the distribution of aeration, and by this way it may increase the risk of ventilator-induced lung injury, and it may improve reduce shunt and improve oxygenation, and finally it may allow to reduce the need for sedation, and by this way may allow to reduce the duration of mechanical ventilation because of earlier weaning. Of course, these advantages, there is a possible price to pay. The risk of spontaneous breathing, I will not come back to the previous talk about the risk of asynchrony. You know that in many patients with ARDS, have a very high respiratory drive, leading to a strong respiratory effort. It may increase the work of breathing and also the oxygen consumption and CO2 production by the respiratory muscle. It may, once again, lead to severe asynchrony. And it may lead to high transpulmonary pressure, and this high level of transpulmonary pressure may lead to the so-called now patient-safe inflicted lung injury. And there are some very nice experimental data coming from Takeshi Yoshida, for example, showing that in animal models of severe lung injury, early spontaneous breathing may be risky. So to try to assess the impact of early spontaneous breathing in patients with ARDS, with my two friends, Jean-Christophe Richard and Laurent Brochard, we designed a multi-center randomized control trial comparing a mode allowing early spontaneous breathing to volume assist control in patients with moderate or severe ARDS. The primary endpoint was hospital mortality, many secondary endpoints, and we have planned to include 700 patients in order to demonstrate a 10% absolute reduction in mortality from 35 to 25%. The mode we use in the experimental arm, the problem is the name. It is a pressure preset mode, allowing the patient to breathe at any time, when he wants, to the two levels of pressure. So, as seen on this slide, on the left, in a patient who is absolutely inactive, it is pressure control ventilation. But in patient with spontaneous breathing, it is a kind of CPAP with two levels of pressure. Okay, so the name could be pressure control intermittent mandatory ventilation, or APRV, but if we call it APRV, it means APRV with a short time, high pressure time. Because initially APRV was a name for a mode with a long period of high pressure and a short period of low pressure. So it is difficult to find a good name. And there is still a debate between Laurent Brochard and me about the good name of this mode. But the idea is that no problem of asynchrony, because with this mode, you renounce to any synchronization. Okay? So the design, a tidal volume of 6 ml per kilogram predicted body weight in the two arms, the same strategy for PEEP, or let's say expiratory pressure. So in volume assist control, 6 ml per kilogram predicted body weight, PEEP for people at 28, and an expiratory flow around 1 liter per second. And in the PC-IMV arm, high level of pressure in order to reach a tidal volume of 6, P-low for people at 28, the duration of the high pressure, T high, between 0.8 and 1 second, and settings in order to obtain a spontaneous breathing activity representing between 10% to 50% of the minute ventilation. So same targets for oxygenation, PC-2, similar strategy for sedation, weaning of PEEP and weaning of mechanical ventilation. And this is the way we adapt the setting of the ventilator and the sedation in the experimental arm. And in order to check the level of spontaneous breathing, we used this graph that was displayed on the mechanical ventilator. In black, it is the total minute ventilation, and in gray, the spontaneous breathing activity. You see that here, this is a patient, it is a 6-hour period. Here it is a patient with a very low spontaneous breathing activity. Here is a patient with a high spontaneous breathing activity, and here a patient within the range of 10 to 15% was the target of the protocol. So the patients were included if they had the criteria for inclusion, meaning ILD, severe or moderate ILDS for less than 48 hours, and then they were on assist control for 1 to 3 hours, and then by randomization, either the experimental arm, that is PC-IMV, let's say, or volume assist control. The sedation, the patient has to receive the neuromuscular blockade agent for the first 24 hours, and then they were stopped. And of course, sometimes they were resumed if needed. But there was the same target for sedation, that is a RAS between -2 and -3 in the two arms. And once again, in the experimental arm setting, in order to obtain a spontaneous breathing activity between 10 and 50%, and in the volume control arm, volume assist control arm, the absence of severe asynchronous. Okay, the same strategy for weaning and SBT, the same indication for prone position recommended for patients with a PA threshold over 150, and same recommendation for the use of it. 22 active centers, 4-year trials, thanks to all the centers who included patients in this study, especially to all the colleagues and nurses. And this is a baseline characteristics for 700 patients, 350 in the two arms. This is a classical baseline characteristics with the main cause of ILDS, like in all the studies, was pneumonia and aspiration. And you see the time since the onset of the ILDS and the inclusion was, the mean time was 17 hours. And this is the criteria, the respiratory muscle on inclusion, the tidal volume before inclusion of 6.4, meaning that in the centers participating to the study, the 600 strategy is applied in daily practice. A paper on a little bit higher than 10, a plateau of 24, a driving around 13, and a PF ratio around 100 and a 35. And this is the primary endpoint. It is a little bit disappointing, so you can imagine no difference in mortality. When we calculate the number of patients to be included, we have planned a mortality in the control arm of 35%, and the mortality in the control arm is 33%, so not so bad. But unfortunately, the mortality in the experimental arm is also 33%. So no effect in this study of the strategy on survival. It is the same thing for the main secondary endpoints. No difference for the death between the mortality. The main criteria was hospital mortality for death during the first 20 days. No difference in the number of ventilator-free days at day 28. No difference for the number of days free of organ failure. No difference for the incidence of refractory hypoxemia, and no difference in the incidence of pneumothorax. Very low incidence in all the studies now with the low tidal volume, the incidence of pneumothorax. It is the pneumothorax, the past history of ALS, with a low tidal volume, the incidence rate. And I think that most of these pneumothorax are linked to some procedure like subclavian CVC, for example. But this is a very important point for us, at least, were able to reach the target. Remember, the target was to obtain 10 to 50% of spontaneous breathing activity. And as a mean, from day 2 to day 7, we are in the target. But look at the standard deviation. It is very big, of course, because due to the difference between one patient to another, in some patients it was very difficult. Of course, in this study, in some patients, still on day 5, some patients receive neuromuscular blocking agent, especially the more severe patients. So it is very difficult. But as a mean, we are in the target. This is the co-intervention from inclusion to day 7. No difference for free loading, no difference for the total dose of epinephrine or norepinephrine, but a very significant reduction in the dose, total dose of midazolam or morphine equivalent or neuromuscular blocking agent in the PC-IMV or APRV arm. And I think this is an important result, but remember that this decrease in the use of sedation did not result in an all-year winning. And this is the results for adjunctive therapies. A lower use of prone position in the experimental arm, no different for recruitment maneuver, for inhalation or for ECMO. And for the difference in the use of prone position, there is two explanations. The first one is that we observed a small but statistically significant improvement in oxygenation with APRV on day 1 and day 2. Maybe it can explain that in this arm there was a lower number of patients with a PA pressure lower than 150. And the other explanation is that when we go back to all the patients who at what time had a PO2 and FiO2 lower than 150, the percentage of patients who were turned prone is lower in the experimental arm. And I think it is easily explained by the fact that doctors were a little bit reluctant to turn prone a patient who were ventilated with a mode that is a little bit difficult to assess, and at least in which it is a little bit difficult to assess the impact on respiratory mechanics of a change of body position. So to conclude, promoting spontaneous breathing using a non-synchronized mode of ventilation did not improve outcome of patients with moderate to severe ALS compared to volume assist control. Spontaneous breathing based on this mode is feasible and safe, and targeting a spontaneous breathing activity above 10% of total unit ventilation permits to significantly reduce the need for sedation and paralysis. Thank you for your attention.